All right, so we can just have people continue to trickle in as we get started here. With that being said, our team at Brown Skin Health is so happy to see all of you here today. And we'd also like to thank, of course, Dr. McKay, our wonderful guest speaker for today, for spending time with us. So, Dr. McKay, you can start whenever you're ready.
Okay, I'm going to share my screen. There we go. Okay, so I'm Cather McKay. I'm a board certified dermatologist. I work in Fort Walton Beach, Florida. Just a little bit about myself. I did my med school at UAB, University of Alabama at Birmingham. I'm originally from Alabama, and my residency at Tulane in New Orleans. And then I finished my residency in 2019. So I'm kind of like in my second year of private practice. So I was excited to hear from y'all, and skin cancer is a big part of what I do, and skin cancer and skin of color is super important and it needs some awareness. So I'm excited about the topic. Here we go. And this is a picture highlighting melanocytes, which is something that we're going to talk about today. Okay, so a little bit, we'll go over skin cancer, the major types, some risk factors, the biologic mechanisms that we have in place to prevent skin cancer, which that includes melanin. So we'll talk about melanin and melanocytes, and then we'll talk about, go into a little more detail on the main types of skin cancer: basal cell, squamous cell, melanoma, and then I'll briefly touch on 2 other types too. Okay, so this is a cross-section of the skin, and the types of skin cancer that arise in the skin are named for the cells that they come from. So here you have the epidermis, the dermis, and the fatty layer underneath called the subcutis. And if you look at the epidermis, you have a basal layer of keratinocytes that are constantly turning over to give rise to the squamous cells, which are just the keratinocytes above the basal layer, and they kind of mature and then slough off. So basal cell carcinoma is the most common type of skin cancer, and it comes from the basal layer of the epidermis. And then squamous cell carcinoma comes from the cells above the basal layer. And then melanoma comes from melanocytes, which live along the basal layer as well. And there are a lot of other less common types of skin cancer, or cancers that can arise in the skin. And they're really anything that's in the skin can give rise to a type of cancer. So there's nerve cells. Merkel cell is a type of nerve cell that you can develop a carcinoma from that. Sebaceous carcinoma from the sebaceous gland. Cutaneous T-cell lymphoma can come from the white blood cells that live in the skin. Dermatofibroma sarcoma protuberans arises from connective tissue, and Kaposi sarcoma from the blood vessels. So these are all much less common, but they still can present in the skin. So the main ways that we talk about skin cancer is kind of 2 main categories: melanoma skin cancer and non-melanoma skin cancer. And when we say non-melanoma skin cancer, we're typically talking about basal cell and squamous cell. But overall, skin cancer is the most common cancer of any type, both in the US and around the world. And 1 in 5 Americans will develop skin cancer by the age of 70. So super prevalent. Basal cell overall is the most common type, with at least 4.3 million cases a year, probably more because it doesn't get recorded the same way that other cancers do, just because it's so common and not aggressive. Squamous cell, still very common, but less so than basal, but with over 1 million cases a year, slightly higher risk of death from squamous cell at around 15,000 per year. And then in terms of the influence of skin color on the epidemiology of non-melanoma skin cancer, as you can see, much more common. So if you look at the annual incidence, and one study broke it down by lightly pigmented individuals and darkly pigmented individuals, much more common in lighter skinned people at 230 cases per 100,000 versus 3.4. So still happens no matter the skin type, but just less common in patients with, or people with pigment in their skin. And we'll talk about why that is. And then basal cell is much in lightly pigmented individuals, happens at a 4:1 ratio to squamous cell. So basal cell is super common in fair skinned people and less common in darker skin types. So melanoma, of course, is the scarier type of skin cancer. Close to 200,000 cases will be diagnosed this year. It's estimated with 6,800 deaths. And again, breaking it down by lightly pigmented versus darkly pigmented skin types, 29 cases per 100,000 in lighter skin types and 1 in darker skin types. So per 100,000. So much less common, but still happens. And then deaths due to melanoma, 4.3 deaths per 100,000 and 0.2 deaths per 100,000 for darker skin types. So less. That's just to give you a frame of reference for how common and that is. So risk factors, largely it's the sun. So UV exposure overall is a major risk factor for skin cancer, tanning beds, ionizing radiation, arsenic and other chemicals, human papillomavirus, so HPV virus can contribute to skin cancers of the genitals and also around the nails. Cigarette smoking also, but it's estimated that 90% of non-melanoma skin cancers are associated with UV radiation. So that's the major risk factor. Pigmentary phenotype, so fair-skinned people and redheads get a lot more skin cancer. There are certain genetic syndromes that make you more susceptible to skin cancer. Having chronic wounds, because skin cancer can arise within chronic wounds and chronic inflammation. So that's another risk factor. And then patients who are immunosuppressed also get more skin cancer, which we'll touch on. So more about UV radiation. So basically you accumulate UV exposure and DNA damage as a result in your skin cells. So over time, your skin cells are acquiring genetic mutations and eventually it can lead to skin cancer. So what is in place that helps protect our skin? So from UV exposure, we have hair that protects some areas. Melanin is a huge factor in UV protection. Epidermal thickening, so the skin will thicken in areas with a lot of sun exposure to try to protect itself. And antioxidative enzymes to try to help repair some of the damage. And once DNA does get damaged, we have a lot of DNA repair going on constantly in the skin to try to repair some of that damage, but it can get overwhelmed with the more exposure and the more DNA damage that you get. Your cells will, once the DNA damage is too much, a normal mechanism to get rid of that DNA damage is actually for the cell to die. So that's part of our protection. And then immune surveillance. So you have your immune system going around trying to find damaged cells. And when they detect them, they can help get rid of them too before they develop into a skin cancer. So melanin, super important. It is a light absorbing pigment and it protects the skin from UV radiation. It depends on how much melanin is in the skin, but it can provide up to the equivalent of sunscreen of an SPF 13. So pretty cool. It is made by melanocytes, so the cells in the skin, and it is packaged into these organelles called melanosomes. And the melanocytes have these dendrites that reach out and touch all of these keratinocytes, and it transfers the melanosomes to them so that they can be protected. So believe it or not, everyone has the same number of melanocytes. So that does not vary based on skin color, but what does give us differences in skin type and skin color is the activity of the melanocytes, the size, number, and distribution of the melanosomes. And also there's different types of melanin. So eumelanin is produced in brown or in darker skin types, and it has a brown or black color or an appearance to it. And then if, very fair skinned people make pheomelanin, which actually looks more red or yellow. So in lightly pigmented skin versus darkly pigmented skin, the size, so darkly pigmented skin has larger melanosomes, more melanosomes, and they're distributed differently and degraded more slowly. So that gives a lot more UV protection. And in medicine, some of what we know about the role of something is when there's a genetic condition where you don't have it. So what happens when you don't have melanin at all? There are a group of conditions called albinism, so oculocutaneous albinism. And some forms you completely have no melanin, and some you just have reduced amounts. But this is an African patient, and compared to other people in his area, they're considered to have 1,000-fold increased risk of skin cancer. So this is all sun related. So lots of pigmentation, precancerous changes, skin cancers. So the risk goes way up when you don't have any melanin. All right, so getting more into the different subtypes. So basal cell carcinoma, it's the most common skin cancer in Caucasians, Hispanics, Chinese, and Japanese Asians. And it's the second most common skin cancer in Blacks and Asian Indians. Amongst all races, these are UV associated. So sun plays a role amongst all skin types. The incidence also correlates with the degree of pigmentation in the skin. So the fairer you are, the more basal cells you could get, or the higher your risk is. Fortunately, this is a low risk type of skin cancer, and the morbidity and mortality is low no matter your skin type. So appearance can be quite different though. So if you Google basal cell, this is what I got. This is what you'll probably see. It's a pretty classic appearance. It's pink, pearly papule. It has these rolled borders. So this is what it can and often looks like in fair-skinned people. There are subtypes that are more scaly or scar-like. And this is in a skin of color patient. It is much more pigmented. So Blacks, Hispanics, and Japanese, one study showed that over 50% of their basals are pigmented versus only 6% in Caucasians. So much more likely to be darker spots. But this is a basal cell on the nose of an Asian male. So still it's a pink papule. So, but also these are all in areas that get a lot of sun. African-American woman, there's a little pearly pink papule right there. The nose of a Hispanic female right here. And this is UV damage as well. This is on the abdomen of a Black female. So it's a little more scaly in texture, but it's very pigmented. It does have kind of the rolled borders along the edges, but your differential would include melanoma. So we'll talk more about that, but you would of course do a biopsy to confirm. Scaly plaque in front of the ear, Black female. Hispanic male, so this is very pigmented. And as you can see, these are big. So oftentimes patients not really sure what it is, or even sometimes the healthcare providers that they see don't really recognize these in skin of color patients. So this is a patient I actually did see myself. She is Hispanic and had this on her shoulder for years and years and years, and had been treated for fungus and all kinds of different things, and it was just kept growing and growing and growing. Fortunately, they do grow very slowly and they're not very aggressive, but still, once we saw her, biopsied her, and had to take care of it, I mean, it was a procedure that she had to have all this removed. So she did really well though. Okay, so the treatment for basal cells based on the histologic subtype. So the pathology report gives you information on that, the size and the location. Sometimes we cut them out. Sometimes they need a specialized skin surgery called Mohs surgery, electrodesiccation and curettage, which is a mouthful, but it basically means you scrape it away and cauterize the base, and you do that 3 times, and that's okay for low risk types. Topical treatments, so there's some topical chemotherapy creams that we can, and immunotherapy creams that patient uses at home for many weeks, and for very low risk types, that is a possibility. Laser, radiation, superficial radiation treatments. Metastasis is very rare. It's well below 1%. And prognosis is excellent overall, no matter race or ethnicity. Next is squamous cell. So this is the most common skin cancer in Blacks and Asian Indians, and the second most common in Caucasians, Chinese, and Japanese. And interestingly, these are highly UV induced in fair-skinned people, but in Black patients, one study showed they're 8.5 times more likely to actually occur in covered areas, which suggests that UV really doesn't play much of a role in those. So you have to think of other risk factors in these cases. So HPV, human papillomavirus, chronic inflammation or scarring processes, arsenic exposure, those are all possible risk factors. So morphology, again, there's going to be some differences. Both of these are hyperkeratotic papules, but in a fair-skinned patient, it's much more pink. In a dark-skinned patient, it's hyperpigmented. So same diagnosis, it's a squamous cell carcinoma, but it can look quite different. So some examples, squamous cell carcinoma, this is a Southeast Asian male. This is a very large squamous cell on a Hispanic male. So that's been growing a long time, probably. This is a large tumor in a Black male, this is squamous cell carcinoma. This is on the scalp of a Black male, squamous cell carcinoma again. So hyperpigmented, also some pink and violaceous areas. And this is around a nail. This is actually a pigmented squamous cell carcinoma in situ, which just means it's very early and it's limited to the epidermis. But this can occur around the nail, and it can be related to HPV. So the HPV, different strains, so make you more susceptible to cancer, so cervical cancer, but also skin cancer, interestingly. And certain subtypes cause warts, and certain ones cause cancer. Subungual, another one around the nail. This is a Hispanic female, pretty large tumor there, destroying her nail. And then this is a patient with discoid lupus, which is a chronic inflammatory condition. And with chronic inflammation, you can develop a squamous cell carcinoma. So that's this nodule here. So these patients need to be watched for any changes in their chronic conditions. And treatment-wise, again, it's based on pathologic features, size, and location, similar to basal cell, excision, Mohs surgery, ED&C, topical treatments, laser, radiation, and sometimes you can use intralesional injections of chemotherapy. These are all assuming it's a local squamous cell carcinoma. There are times when it does spread. Fortunately, that is rare, but unfortunately, when squamous cell carcinomas present in Blacks, it's often associated with increased morbidity and mortality. The one study showed up to 30% mortality. And overall, it's closer to a 4% when you look at all types of squamous cell amongst all races and ethnicities. So why is that the case? So when squamous cell carcinomas occur in some skin of color patients, it's more in covered areas, and including chronic wounds. And those types do metastasize more commonly, no matter the race. But those tend to be the predominant type in skin of color, so they have a higher rate of metastasis. Delayed diagnosis, which can be due to a lack of awareness, both on the patients unaware of that could be a possibility, something they need to get checked out, and also among healthcare providers. And then there's issues with access to healthcare, and there's differences in that, which plays a role as well. Okay, melanoma. So this is the third most common skin cancer in African Americans, Asians, Hispanics, and Caucasians. UV exposure is important, but really it's more, it plays more of a role in Caucasians and Hispanics, and those patients tend to get melanoma on sun-exposed areas. But UV does not seem to play a role in Asians or African Americans, and they tend to get melanomas in areas that are not sun-exposed or not don't get a lot of sun exposure. So we'll talk about that. Dysplastic moles, increased number of moles, family history, and fair skin are risk factors for melanoma. So when melanomas occur in Blacks, Asians, and Native Hawaiians, they are most often to occur in non-sun exposed skin with relatively less pigment, so palms and soles. Also around the nail, and on mucous membranes, so inside the mouth or the genitals. And that's 60 to 75% of melanomas will occur in those areas. And the most common subtype is called acral lentiginous melanoma. And that is, acral just means it occurs on that type of skin, like the palms and the soles. Lentiginous just means it grows, describes how it grows across the skin surface. And superficial spreading melanoma is the more common subtype in Caucasians. So slight differences there. And in terms of morphology, usually it's pigmented in very fair-skinned people who don't have a lot of natural pigment. It could be pink. It could be a melanotic type. So, but usually it's pigmented, asymmetric. Macule just means a flat spot. So it could be, completely not palpable, meaning you can't feel it. It's just a flat spot. Or it could be a little raised. That means that's a papule. Borders are irregular. So that's the most common morphology, but I'll show you some pictures. You can get irregular streaks in a nail that is a melanoma, or you could have a long-standing mole that changes or starts to bleed easily or something like that, and it's a sign that it could have developed a melanoma. So these are two patients of mine. This was a melanoma on the leg of a Caucasian lady, very irregular, so asymmetric, multiple colors. There's pink, black, brown, borders are irregular, so clearly a melanoma. This was a less obvious melanoma because sunspots can look quite similar to this, but there was enough irregularities in the color and the borders that we biopsied it, and it was a melanoma. This is a melanoma on the leg of an African-American woman, and the borders are irregular. There is a color variation, darker shades of brown and black and lighter shades. And then of course this is a flatter area and it becomes more nodular. So that's very irregular. And then these are some melanomas on the bottom of the foot. So just super irregular. More pictures. So melanoma on the foot of a Black male, just irregular papule. This is a pretty advanced melanoma on the bottom of the foot of a Hispanic male. This is a nodular melanoma on the leg of a Hispanic male. So this is a different subtype where the melanoma just develops as a nodule. So sometimes brown, black, pink. An irregular patch, really hyperpigmented patch on the leg of a Black female became back as a melanoma. Hispanic female, so this is, there's a lot of times that nail pigmentation can be normal. If it occurs on multiple nails at one time, it's sometimes induced by trauma, but there are certain features that make you more suspicious for a melanoma. So the nail matrix is under this fold here. So there's cells here that are producing the nail plate, and there's melanocytes in that area. So as the nail grows, if the melanoma is producing pigment, it can make the nail plate pigmented, and it's an irregular, it's a broad, usually, normal streaks are thinner and just very regular in their color. The pigment extends onto the nail fold. That's another clue. So nail lesions can and should be evaluated if they're new, changing, if only one nail is affected. And, sometimes we have to go and biopsy the nail matrix back here. So this is an example of a melanoma. And this is probably a more advanced melanoma around the nail, but as you can see, it's growing all along, even the skin all around the nail. And this is a very advanced melanoma on the nail bed of a black male. And this is what Bob Marley died of, unfortunately. So they always heard toe cancer, but it was melanoma of his toe. So melanoma treatment, it's largely based on the stage at diagnosis. So the earlier the stage when they're diagnosed, the easier it is to treat and the better their outcome is. What we look for is when we do a biopsy, we look at how deep it is. So and based on that depth, we may or may not need to sample a nearby lymph node. And so if it's early stage, very early thin depth, then you might just need to cut it out and just follow and have close follow-up. If, of course, the lymph node is positive or there's evidence that it's spread anywhere, that's much more aggressive and needs more aggressive treatment, immunotherapy, chemotherapy even. So it all depends on how deep it is and whether or not the lymph nodes are involved. So prognosis. So unfortunately, melanoma is diagnosed at later stages in patients of color. So late stage diagnosis rates. So over 50% of non-Hispanic Blacks are diagnosed late, 26% of Hispanics versus 16% of non-Hispanic whites. And the 5-year survival for melanoma overall in Black patients is 70% versus 94% for whites. So why? We'll talk about that. This is a busy chart, I know, but I thought it was really displayed this well. So comparison of the characteristics of 49,000 patients with melanoma according to race and ethnicity. So looking at their stage, so there's 4 stages of melanoma. 1 and 2 are the earlier stages. They are, 1 is very thin, 2 is just a little bit deeper but still limited to the skin. 3 is when lymph nodes are positive, and 4 is when there's metastasis to other organs. So looking at the different races and ethnicities, white people, of course, the numbers are much higher because white people get more melanoma, so 48,000 patients, but 80% of those are diagnosed very early versus only 4% are already metastatic when they're diagnosed. If you look at Hispanics, African Americans, American Indians, and Asian Pacific Islanders, much higher rates of already metastatic melanoma at the time of diagnosis, above 16% in African Americans. Now, these numbers are lower in terms of overall patients, but of course, I mean, it's very clear that patients of color are diagnosed at later stages. And overall survival, this is called a Kaplan-Meier curve. It looks at survival. So this is the percentage of or probability of overall survival and over time, over the years. And it breaks it down by race. The white patients are in red and they have the highest overall survival, and African Americans are the lowest. And then everyone else kind of falls in between. So why? Again, delayed diagnosis. And that is due to a lack of awareness and, both with patients and unfortunately healthcare providers, lack of access to healthcare. So similar to a squamous cell. Also the tendency to occur in more conspicuous areas. So meaning like the bottom of the foot, not everybody looks at the bottom of their foot very often. So sometimes it goes unnoticed. But interestingly, even when you control for location, type of melanoma, age, sex, everything else, there's still a worse prognosis, particularly in African Americans, and we don't know why that is yet. So that is yet to be determined. And then briefly on two other types of skin cancer. So DFSP, dermatofibrosarcoma protuberans. Overall, it's pretty rare, but amongst skin cancer in Black patients, 10% are DFSPs. And so Black patients have a higher incidence than Caucasians and Asians. Unclear why that is. They are often violaceous or hyperpigmented nodules, very firm on the trunk or extremities, could easily be mistaken for a keloid. And actually, a patient I saw told me he had a keloid on his hip, and not to worry about it, but I kind of pushed him to see it, and it definitely was very irregular shaped, no history of trauma. So we biopsied it, and it was a DFSP. Now, they don't spread that often, but they can locally be very aggressive, meaning they can just grow very large and be kind of, once it's hard to get margin control, and they can recur often, which just is, so locally it can be an issue. This is another one, and that occurred, trunk and extremities are the most common locations for these. And then the last thing, so cutaneous T-cell lymphoma is something that most people have never heard of, but it is a type of lymphoma that happens in the skin. So we have a lot of white blood cells that live in our skin as part of our immune system. And sometimes they can become atypical and proliferate, and you get what's called cutaneous T-cell lymphoma. So Blacks are 2 times more likely to be affected than Caucasians. It can present as looking like a rash. So patches, plaques, sometimes even nodules or tumors. More commonly, it's patches and plaques. And they can be hypopigmented, and that in darker skin types is the more common type, actually, is to be hypopigmented patches and sometimes plaques. So sometimes people think it's eczema or something else, and it can go misdiagnosed or unrecognized for long periods of time. It's often just a chronic, not just, but it's often a chronic condition that you manage, but it can spread to the lymph nodes or the internal organs. And when that does happen, it is the mortality rate goes up. So, conclusions. Skin cancer, while it is less common in skin of color patients, it is associated with increased morbidity and mortality when it does occur. So what can we do? Education is a huge need to increase awareness, both patients and throughout our medical school training. So a good an initiative actually of the Skin of Color Society is to include more images of skin of color patients in educational materials. So even just out on the internet or in the pamphlets we give out, about skin cancer, in our textbooks, a lot from, it's usually pictures of light-skinned people. So including images, because there are different appearances that need to be, that patients and healthcare providers need to be able to recognize. Improving access to healthcare, obviously that's a big issue, but would help. And encouraging self-skin exam and sun protection, no matter the skin type. So dark-skinned patients often think they don't need sunscreen, but try to convince them otherwise. And then monitoring chronic wounds or inflammatory conditions. So that becomes the role of the dermatologist or primary care or wound care. When something doesn't look right or is growing in a different way, then it needs to be biopsied. Some references, and that's it. This is, so just a plug for the Skin of Color Society. They have a lot of good resources. The American Academy of Dermatology is good too. So if there's any questions.
Thank you so much again, Dr. McKay. So as she mentioned, this is now the time for questions. So if you have any, feel free to unmute yourselves or send them in the chat.
Okay, so what was the one's question is, what was the most common type of melanoma found on the trunk area? So on the trunk, typically it's the superficial spreading subtype of melanoma, and the back is the most common place for white males to have a melanoma, and the back of the leg is the most common place for white women, but hands and feet, the palms and soles are most common for Asians and Black patients to have a melanoma. And next question, could you please go over what Mohs surgery is and when is it best used? And there's a fellowship for Mohs, yes. So Mohs surgery, it's named after the doctor who invented the procedure. So that gets a lot of questions like, what does that mean? It's not an acronym. It means it's just named for the doctor who invented it. Basically, you take a skin cancer. This is typically a dermatologist that has a fellowship training in Mohs surgery. They cut right around the skin cancer and look at it under the microscope while the patient waits. And they're able, the way that they section the skin, they're able to see all of the margins, if you think of it like a bowl. So they're able to look at all the bottom margins and all around the edges of the skin cancer. And they can see if microscopically there's any extension in any location, and then they can go and just take that location, check the margins again until the tumor is cleared. The benefits of it are that it's tissue sparing, so you're not taking a lot of extra skin. Because you're able to check the margins immediately, you can just take what you need to clear the tumor. So places where you don't have a lot of extra skin, the face, backs of the hands, fingers, feet, genitals, or just for very large tumors elsewhere that you don't have a lot of extra skin, or it would be hard to remove, because I do excisions, but I have to take a large margin around it to clear the tumor. But a Mohs surgeon could just take what they need to clear it. And then they do the reconstruction typically as well the same day. And do you see a diverse patient population in your private practice? I do, to some extent, not as diverse as I would like. I'm not sure what just in Florida, I see a lot of fair-skinned people who have a lot of sun damage, but I do see some different skin types and ethnicities for other reasons. I wish it was more common to do skin checks on skin of color patients. It's just not something that people come in asking for that often. When I trained in New Orleans, much more diverse patient population, so that I enjoyed that. Does the morphology of melanomas ever return back to the patient normal skin appearance before it is treated, or does that mean it is not melanoma? That's a great question. So typically, a melanoma would not go away, typically. There is rarely a time when we think melanomas can regress. I wouldn't be too concerned about that. But typically a skin cancer is not going to go away on its own. And if it does, that's usually reassuring. I don't want to get too in the nitty gritty, but it's usually not going to heal and go away.
Right. I actually have one last question, sorry.
Yeah.
So you mentioned earlier that skin cancer is more common in people with fair skin, but I recently saw a journal article from the American Academy of Dermatology saying that medical students are more likely to correctly diagnose skin cancer in lighter skin versus darker skin. So with the level of technology and resources available to us, how do you think the medical school education system is adapting to better educate their students? If you have any knowledge on that.
Great question. Actually, Tulane, I think the study you're referring to was actually done at Tulane. And yes, so basically it's just highlighting that, so as medical students, you don't yet have a ton of training in dermatology. Some med students don't get a lot, and some maybe seek it out and get some elective training where they can better diagnose things just clinically by looking at them. So it just highlights that it's much more common that people can recognize skin cancer in lighter skin types, probably because that's what you see in the media and online, in all our pamphlets and textbooks. So it just highlights that we need better or more diverse, diversity in our education, our textbooks, even for medical professionals. And as far as efforts to get that done, I think the Skin of Color Society is pushing for stuff like that. But even so, Visual DX, I don't know if that's an app that a lot of residents, and I even use it as a dermatologist to quickly reference things. They're taking a personal, making it one of their missions to include more pictures in Skin of Color patients. So it's getting a little bit more attention, rightfully so. So that I don't know of any other like technology-based things, but yeah, it's getting better, but we have a long ways to go.
All right, thank you so much. I'm sure I speak for all of us when we say we were so grateful to learn from you today. And if any of you guys want to keep following Dr. McKay, she is on Instagram. We will tag her. She was tagged in our most recent post, so you can find her there. But if there are no other questions, thank you. And I hope the rest of you guys have a good rest of your day. All right.
Thank you.